I'd like to welcome you all to the Prevention Research Center for Healthy Neighborhoods seminar series. This is our monthly seminar. I'm Sue Flockey. I'm one of the associate directors of the PRC, and it's my distinct pleasure to welcome you all. It's nice to see some new faces and some familiar faces. This is a monthly seminar. We have a variety of topics that we invite and host. Many local speakers, and as well as some speakers from across the country come for our seminar series. Today, I have a distinct pleasure of introducing our director of the PRC, and really excited to hear about this study that's been going on for quite a while. We'll get a bit of the background, we'll get a bit of the story, but I do want to acknowledge there are a lot of people in the room that in some way touched this project. And can you, if you were involved in this project,
raise your hand.
Some way?
In some way.
So I just want to acknowledge that this was a major effort. I'm really excited because this is the first time I'm
I was just going to say
the findings. I know that they've been presented nationally, but this is the first time I'm really going to get to hear the whole story, and I'm really excited about that. But let me introduce Elaine Borawski. Many of you know her. She is the Angela Bowen Williamson Professor of Community Nutrition and is a professor in the Department of Population and Quantitative Health Sciences and Nutrition at the School of Medicine. You know that she directs the center, and that she also has a strong interest in social and environmental determinants of health, and has been a strong advocate of that and working together with community partners in her research. And I think that that's really highlighted strongly in this research project. So with that, I'm going to turn it over to Elaine.
Hi, everybody. All right, let me make sure I know how to do this. And the blue light's on. So I'm good? Okay. All right. So this has been a long time coming. For those of you in the room, some of you have been. This project became an idea almost 10 years ago, and literally was a 7-year project that finished about a year ago, less than a year ago, and now we're in the process of all the data analysis. So today, we gave the talk nationally, and we've given a couple local talks, but this is the first time now academically. I give this talk on behalf of myself, of our leadership team, Shirley Moore from the School of Nursing, and as those you know, Leona Cutler. We were the three musketeers in putting this together initially, and Leona very sadly died in the second year of the project. But she really was the impetus for this project and for bringing the three of us together, which had never worked together prior to this. But she had an idea of how do we approach obesity from a clinical standpoint, from a behavioral intervention standpoint, but in a multi-level and multi-setting approach by involving the community level as well. But, did I do this right? Yes. But as Sue has mentioned, it is a huge team. And a project like this takes a huge team. As you'll hear more about the study, you'll realize that it was really had to be broken into different components. There's a clinical core that was responsible for bringing the kids in and the assessments. There was the intervention core, which took responsibility of all the interventions at the family level. And then we had the school and the community core, which was relationships to the school intervention and the community level data. And then tagged to that, much to this group in the front, got tagged with also responsibility of also pulling all the data together. Truly, on behalf of Shirley and of Leona, I want to say thank you to everybody if you're in the room and to everybody on this page. And boy, I hope I didn't miss, I'm sure I did miss some people, but it really was a huge endeavor. And really, Terry, I don't want to make you sad, but I really want to say, too, to the clinical core, you know, their leader left in the second year of this project. And I know you guys did what you did the whole way in Leona's memory. And so I really greatly appreciate all the work you guys did. Okay. So a little bit of background. So the project is called Ideas Moving Parents and Adolescents to Change Together, or IMPACT. Oh, hi, Michael. His name was up there too. You'll say, welcome. So as we said, it was a 7-year study funded by NHLBI, one of the Institutes of National Institutes of Health. But the interesting of this story is that we were not the only study funded. There were 4 studies funded under a consortium called the Childhood Obesity Prevention and Treatment Research Consortium, or COPTER. And there were 2 prevention trials funded and 2 treatment trials, and I'll tell you a little bit more about them. When this FOA came out, it was unique because NHLBI had already tried a number of efforts around childhood obesity. And this time they were really adamant that this was going to be, they wanted to see what it would take. And so the FOA required it to be not just individual level, not just family level, but to come up with a multi-level or multi-setting approach to childhood obesity. They really believed that maybe in the past the interventions didn't last long enough. They were often, typically, we do intervention research, you do intensive interventions for a year, and maybe you follow folks for a couple more years to see what the lagged is effective. But they wanted 3 years of hands-on intervention with a priority of low income and minority youth and their families. So this is a challenge. Those of you that do this kind of work, keeping any of us engaged in an intervention for 3 years is a significant challenge. One might imagine the families that are moving and having a lot of resource issues, that a 3-year intervention or a commitment to a 3-year intervention is challenging. So the study itself was to engage at least 1 child that met the criteria we'll talk about, and then 1 parent. And what made this probably what it turned out to be in many ways was that all 4 of the studies were managed by a research coordinating center or coordinating unit at UNC Chapel Hill, who served as our research coordinating team. And they serve as investigators, but they also they also were the stick in the carrot a little bit as well. As you'll see, the data was collected in a very rigorous way, mainly because of the work they did. They collectively trained all 4 centers. All the measures were very tightly controlled. So these are the 4 studies. Oh no! Sorry, Minnesota, I lost their logo. I don't know what happened to it. Is it there? Nope. Anyway, okay, so these are the 4 studies. As you can see on the left, 2 of them were prevention studies. So they started with little kids. So again, 3-year intervention. Minnesota started with 2 to 4-year-olds, with kids that were over the 50th percentile. And theirs dealt with home and primary care, sort of primary care, and family groups, and literally going into the homes. Vanderbilt's was very interesting. They work with 3 to 5-year-olds and the families, but really their focus was getting families to use their local parks and recreation resources. It was truly going somewhat through their primary care, but the idea of really getting folks to know what was available to them and using them. So that's the prevention side. On the treatment side, it was Stanford University and us. Stanford engaged groups of kids that were 7 to 11. Their kids are, like ours, over the 85th percentile at enrollment. Home primary care, they did a really cool, unique sports program that engaged kids in their own kind of inner, I don't know, would you call it? Extra fitness program or sports program. And then there's us. And so our kids came in around, you'll see, around 11 and a half years old, again at the 85th percentile. And as you'll see, our settings were family groups as well as the school setting. This is just a picture that was taken just recently when we presented the findings at the Obesity Society. And these are the investigators, if you're familiar. And I did realize after I put this outfit on this morning that it's so this is obviously my presentation outfit. So what do we know? Why multi-level? Well, we know that kids, people don't live in a vacuum. Children particularly, somebody typically feeds them, or at least brings food to them. Or as they age, though, the outside environment also has a role. So we know that the family plays a big role. There's all kinds of aspects about the family, both about the eating patterns and the shopping patterns and the resources that families have. But school plays a very big role for kids. And as well as the neighborhood. Come on. There we go. Very interesting. Like some of the pictures just start showing up. Is that odd? There's a couple that are missing. But anyway, the idea that a child, lives within a family, goes to school, lives within a neighborhood. This study really embraced that concept of saying how would we look at childhood obesity within that context. And so, as we said, just as this is called the socioecological model, the idea of doing interventions that both involve child family, child school, and even at the community level. So overall, our research question, primary research question was, which of 3 different family-based or family-level interventions would be the most effective in reducing BMI in children who were already at the 85th percentile or higher at the beginning? But we also wanted to know, in addition to those family interventions, what would the role be of a supportive school environment? A school environment that provided a very interesting program you'll hear a lot about. If you don't know about We Run the City, an opportunity where there's already a built-in opportunity for physical activity in the school. So we know the kids don't move a lot, but if we could look to see if this opportunity would in fact improve the impact of the family-based interventions. I won't go over this too much, but other than to say, okay, where's my, Jenna, my pointer is where, in the middle?
Middle.
Someone have forwarded it.
There you go.
Okay, so as you can see, so here's our interventions. This is our primary outcome. We were mostly, we're interested in BMI. You'll see that BP is in here. And when we started this 10 years ago, looking at this, we had a lot of data from Rerun the City that seemed to imply that the kids at this age were starting to have elevated blood pressures. And so initially we were thinking that this would be a large part of our outcomes. As you'll see at the end, at the beginning, the kids, at the 7-Eleven, the kids actually, there weren't enough kids that had actually significant elevated blood pressure. So that moved into a secondary outcome. But as you can see, we're also interested in secondary outcomes around cardiovascular health, around fitness, cost effectiveness. But obviously, we know that these things, they may happen on their own, but for the most part, they happen through a mediating process, right? And if you think of what does the nutritionist tell us, right? If you want to lose weight, what do? Reduce calories, move more. And now we know, though, more and more too, though, that sleep plays a role in obesity, stress plays a role in obesity. So many of these, and also knowing that sedentary behaviors are not the same as the opposite of active behaviors. Kids can be highly active and highly sedentary at the same time. And so looking at those two things separately is also very important. So one of our, obviously, hypotheses is that hoping that the interventions would have an impact on these behavioral changes, which in fact would in turn then have an impact on the health outcomes. And then mediators also was, these are the theoretical mediators, meaning that each of these interventions, especially the healthy change and systems change, are based on theoretical frameworks and models and theories that suggest that if you change, for example, if you can improve social cognitive models of those you know, self-efficacy, if you can help somebody believe that they can make a change, there is a better chance that that health behavior change will happen. There's a new concept here, and I'm going to talk a little bit more. Shirley Moore developed an intervention called systems change, and she has developed this intervention with adults, largely with adults with cardiovascular disease. And so this was the first attempt of taking that intervention and tailoring it to a younger family, a child, and a family. We'll go into a little bit more about that. And then this part is probably where our group at the PRC plays this is where our role is. Because what we really wanted to know was two things. This was the moderator. What impact would there be if the kids who were in these family interventions also happened to be in a school that had We Run the City? And I'll talk more specifically about that. But also here, we also know, and we know a lot of it here being in the PRC, we know that individual and families have a lot of context happening, right? Whether it's their family context, whether there's a neighborhood context, the larger community context. While this was not initially an aspect of the intervention, it has become a very large part of the study and where we're going to head now, and you'll see why in a bit. That's just the summary in writing of what our aims were. Okay, so very quickly on the intervention level. So healthy change, for those of you that are familiar with RBNCs, and I never get this right, Terry, healthy weight, healthy family, healthy kids. Okay, thank you. Yeah. So it really was tailored after that program. It's theoretically a social cog-based model, which is a lot about problem solving, setting goals around diet and physical activity. Traditional methods for getting children and families to look at their dietary and their physical activity. The systems change is different in the sense that it's based not on motivation, it's not on problem solving, it's about looking at your life. I'll say that. Looking at one's family life, looking at our systems and our routines, and seeing if there's things that you could try that would change your diet or your physical activity, sleep, or stress outcomes. So Shirley always tells one of the best examples is, how many families don't shop with the shopping list? How many of you shop with a shopping list? Very good. Does it control what you buy? Typically, yeah. So surprisingly, what Shirley finds, it also, like she says, it also helps you to stay sort of typically on the outer skirts of a grocery store and not necessarily on the inside, which we'll talk about that more. But this idea was families would look at their routines and try different kinds of interventions. And then the last one, called Tools for Change, was our control sample, or control intervention. And this is what the children would get if they came to their primary care, and the primary care doc says, I really would like you, to the parent, to maybe engage with a nutritionist. And so they received customary meal plans, got literature about dietary, physical activity, stress, information. You'll see later they were followed. There were some activities, but not the intensive activity level of the other two. So here's some examples of some of the activities. I will say up front that pictures were taken with consent. So you'll see a lot of pictures from Rerun the City, because the Rerun the City has the consent as a part of the packet. With our program, there are only a few that actually, with the interventions, there are less pictures. So healthy change and systems change. In the first year, they met every 2 weeks throughout the year. And those meetings happened in the community. Many of those meetings happened right in this space right here. And then in the next 2 years, they were followed up with monthly face-to-face calls, meetings, and phone calls. The control condition basically got the 1 hour diet and physical activity counseling center session, 2 social phone calls, and group events each year. So just as a background then, so these sessions were held in the community. Transportation was provided via a gas card or taxi. Families were invited, so not just the children and their parents, but they could bring as many people in the family that they wanted. There were times, I understand, that this room was just packed because people would bring 5, 6 people if they were doing especially an event around trying different kinds of foods. The special activities they would do grocery tours on how to choose healthier fast foods, a variety of other physical activity opportunities. The facilitators in both of these interventions were systematically and rigorously trained and retrained over time. All of the sessions were recorded, and there have been very tight fidelity records been kept. I wanted to put this up just so that one of the things I think people would ask is, 3 years is a long time. What do you do to keep people engaged? This is an example of just what was happening in the 3rd year. So just to explain that the intensity continued all 3 years. So they continued with 4 social activities. They would get 8 monthly phone calls across the year. There was a passport program developed that gave them a chance to go try things in the community, and they'd get a sticker and then be potential for a prize. There were monthly challenges, and then they would receive these packets that had a wide variety of things to support healthy living in the families. So pretty intensive all the way to the very end. I love my best part, the favorite part to me though. The very last session, Shirley's group hired a photographer, and they were invited to bring their family members, and there was a family portrait taken and given to them as their final gift. So the Obama's portrait came out right around the same time, so it's been, I've kept the presentation, and they kept it in the presentation. Okay, so that's the family base and the family level. And the school-based program, is like I've mentioned, is a program called We Run the City, which is run by the Cleveland YMCA. It's in its 12th year? 13th?
13.
Wow, okay. So I will say that Barb Clint and Alan Armstrong, I think, really, A very unique program that came out of the Steps to a Healthier Cleveland grant, and it has gone strong. And it's mostly gone strong because of the continued commitment to this. This is a program where kids in Cleveland schools, and I've always loved the fact that it's been kept to Cleveland schools. The kids are part of a team in their school. It's led by a teacher or some other personnel. Sometimes it's another teacher from another grade. It can be a custodian. It can be anybody who chooses to be the teacher. In January, they're recruited, and they practice in their school for 12 to 14 weeks. Something that's either running and walking and a lot of other parts of the curriculum. But then they actually participate in a portion of the Rite Aid Cleveland Marathon. So it's a pretty remarkable thing if you've not seen it, because a lot of the kids, many kids have never been out of their neighborhoods. So not only are they seeing this, but to run down the street and have everybody clapping for them as they're going down the street is a pretty amazing thing. I think it's amazing because they also run in over the bridge coming in over the lake, and it's quite remarkable. So we really were lucky to tag on to this natural experiment in some ways, because this is a program that goes on. What we did as a study then was to provide, navigators. So that we had a whole team of navigators that were assigned to any school or team that actually had one of our impact participants in it. They participated in everything from the conditioning clinics to the in-school training. You should understand, too, to give a perspective. We talk about this a lot. When you were a kid and you were in high school, you might have ran track. Where did you run that track? First of all, inside or outside? Inside. Some inside, okay. Mostly outside, right? Usually on a what? Track, right? Many of the We Run the City kids, teams, they do their running inside the school. That means through the hallways, up the stairs, down the stairs, because there isn't a safe place. And I don't mean safe necessarily by crime, but safe from dogs and sidewalks that are broken up. So this takes a lot to stay engaged in this program for a kid too, because it is about doing things you wouldn't normally do and running through your, although it might be a fun thing to run through the classroom after school. Okay, so the kids in the impact study, if they were in a school, had the potential of being exposed to this program for 3 years. All right, so now I probably should have done this at the front end. Sorry. So this is the recruitment. So to be in the impact study, you had to have a body mass index of 85th percentile or higher. And the recruitment came from from a very interesting, and I thought at the time, a very innovative approach. So oftentimes when we're dealing with childhood obesity, we go where for recruitment? Doctor's offices. So so you're going somewhere where the child has already now viewed themselves as a patient or as being an overweight child, right? The idea here was to go in through the school screening program. So we were very fortunate at the time, and now the Case School of Nursing does BMI screenings across Cleveland. And so with their help, and then our PRC did it for a number of charter schools, we were able to use the screening program to identify kids that potentially could fit into the program, and then we helped assist with the letter that went out, and then parents could then opt out of not receiving any other letters from us, and then the recruitment went from there. This is looking at Terry right now. This is sounding like this was an easy thing. It was a very interesting experience to go through the whole recruitment process, right? So anyway, basically the children then at the 85th percentile were invited to come in to be fully screened, and then those meeting the full criteria were invited. So the kids came to either RBNC or Metro. I don't know that we had that many actually go to Metro, did we, at the end? A few. So the kids come for a full assessment. When they come, both the parent and the child were weighed, and then the child received a number of other anthropometric measurements. The child had a physical exam with a physician, their blood pressure was taken, and their blood was drawn. The blood was drawn at their baseline, and then at 1 and 3 years. I'm going to say, as the PRC director, I will say it this way too. I was adamant against this, adamant against the blood draw when we started this. Because my thought was, these are not patients, these are not kids. I know my own children, they don't even like getting their blood pressure taken. Thought this was just not a good idea, right? And I also didn't think they would do it. And I've been, not only am I part of is the team, right, and the ability to really to explain things, but in the end, I think we've learned that those blood draws were very, very important for these families. For a really important reason, because after they came, Terry and the team would send a letter to every parent explaining them what the results of that blood draw was. So every year of the 3 years, or 4 years, basically, they got 4 printouts of what their child's health was really like. I don't think I realized till now that many families don't get that information from their physicians. And so in many ways that ended up turning out to be a far bigger incentive in this program than I would have ever anticipated. So after they came in, they then, you'll see a whole set of questionnaires they completed on either face-to-face or on a tablet. They were then sent home with an accelerometer, right? Not quite like this, but for 7 days, they were to wear it for 7 days. We took 5 days of data from it. They also would then receive, where's our crew in the back of her, they would receive 3 phone calls to do their 24-hour recall. There's wonderful ladies in the back, so calling them and saying, okay, I don't even know how it actually is done, right? But so you take basically weekdays and weekends, and so you get a sense of what their overall diet. They were given $100 and also mileage or transportation and a meal voucher. Once they had completed all of this, then they were randomly assigned to one of the 3 family groups. In the end, we recruited 360 families. When we started, they all lived in the city of Cleveland. I'm just going to whip by this because I just think it's kind of fun to show all we have. Also because I'm hoping that some of you out there might be very interested, especially in students. There's some wonderful data here. It could use being mined. And so there's a lot of information. So this is all the data that we collected from the children themselves, the self-report data. And here's all the information that we collected from the parents. So the environmental context. At the beginning of this study, I don't think we really embraced it. It grew over time because we began to realize how important the environment was going to be. So we have a whole series of environmental context data. Clearly, obviously, the data we get from the census tract data, but for every child, every address, we did something called a neighborhood attribute inventory, which means you go out to the block. Now the kids, the staff going out to do the inventories don't know where the house is. They just know that it's somewhere on this block. And they are doing an assessment of both sides of the street. We said in the grant we would do this at baseline, and we would do it at 36 months so we could see how the environment had changed. What we didn't realize is that almost 50% of kids moved at least once. So every time they moved, we did a new assessment. Many families moved 3 or more times. So we have environmental data on their block every time they moved. So that's I think in the end later will become a very important factor. We also were very fortunate. At the PRC, we have something called NEAP, or the Neighborhood Environment Assessment Project, which does something called the Food Retail Audit System. Yeah, it has a lot of different names. Every summer, we hire a small army of students as interns, and they go throughout the city and basically assess all the food retail in the city of Cleveland. And that means not just grocery stores, but also gas stations and fast food, and I'm trying to think space in here, guys. What else am I missing?
Food trucks?
No food trucks. No, but small, yeah, physical spaces, but not just grocery stores is my point. We also have been fortunate, and we have not really pulled into this yet, but we've been fortunate to tie the Youth Risk Behavior Survey. Jean, are you here? Where's Jean? She was here. Oh, there. So Jean leads a team that does the Youth Risk Behavior Survey in all the Cleveland schools. And so we've been very fortunate to our teams to get together, and we're able to link the impact kids to data in their schools. So we now know what the norm is for that child for that year. So we have a sense of what kids in the school feel like and what their own behaviors and activities. And then lastly, at baseline in 36 months, we did a school food environment assessment, literally going into all of the Cleveland schools, doing assessments on things like their lunch menus and thinking, do they have bake sales? Do they have things like that? What is the environment within the school? Okay. That's halfway through it. This is a lot longer than Okay. So the description of the characteristics of the study groups. Remember what I told you about the FOA saying the folks had to be overweight. Let me just go here. It's easier to do it this way. So Our population ended up being over 90% minority. Of the other half of that is also mixed race. So we did a very good job of recruiting both by race and ethnicity. The kids, as you can see here, are one third of the kids were overweight, between 85th and 94th percentile, and 2/3 of the kids started out with BMIs considered to be obese. Okay, these were not recruited this way. As the kids were recruited, this is who came in. But there were no significant, important to the science part of this, there were no significant differences in any of the intervention groups across these variables. This is the parent characteristics, which I think are very important to note also. Probably this one is the most, is 71% of the families that entered the study were receiving SNAP or food stamps. So highly food insecure. Obviously, you see almost 50% are living on incomes as families less than $25,000. So again, I just would like to pause with that so everybody have a good sense of who the families are, what resources they have, and just the commitment they made in light of this, you know, the moving and the resources to come in and invest in this program for 3 years. Also notable is that if you know that for adults, BMI over 30 is considered obese, that on average, the moms of the kids, the majority were also considered obese. I don't have it here, but I believe that over a quarter had BMIs over 40. So moms that are also obviously struggling with the same issues. But again, no parental differences by group. Okay, so very quickly, just to get a sense of the exposure piece of this. So this is the dose. We have very rigorous records on how often kids attended and how many minutes they attended. So this is the dose for the family sessions. So as you can see, across the two different interventions, on average, the kids receive somewhere between 26 and 30 contacts across the 3 years, and receive somewhere between 21 and 24 hours of intervention. That's across, remembering that that's taking kids that dropped out of the intervention early on as zeros. They are averaged into that. And that's why you can see that the range, we have ranges from 0 to all the way up. On the We Run the City, this is so remembering that not everybody's in this, and I think it's real important for those of you that are researchers that understand this, is that the kids that were in the family intervention were not then randomly assigned to the We Run the City. It was the idea of doing a natural exposure, a natural experiment where you have this experiment, but so even the control kids could be exposed to the We Run the City. Does that make sense? So this is across the board intervention for everybody. So of our participants, each year about a third of the kids were in a school that had We Run the City. Of those that were in the school, about 50% joined, and of those that joined, about 55 to 60% stayed with the program to the very end, and most typically ran in the race at the end. I think I'm not going to spend too much time on this, just other than to say, again, lots of rigorous. We know how many minutes they attended, and this comes into play a bit later. We know how much actual dose they got, right? So We Run the City, it's not just being on the team. We know how much they actually walked and ran. Okay, so this is just important to know about the transient nature of the population. I think the bottom part is the most important, that 48% of the families moved at least once. And as you can see here, almost 20%, or over 20% moved at least twice. Among this group, there are some that moved 5 and 6 times. Okay? But, and this is where I want to clap, because this team followed these families anywhere they went. So at each time period, over 90% of these families were seen. Unheard of. And I will say, not just as I'm saying it as a proudness of the team's effort, because to have this population that moves as much as they do, a lot of, how many phone numbers? I mean, every family could have hundreds probably by the end of it, right? Because people are moving and changing. To keep on this and to have families, but it also suggests that the families were committed to the study as well and very interested in retaining. Okay. Now we'll get to the big, sorry, nobody taking the whole turn. So real quick, I'm going to go over the primary outcome. So this is where we basically hypothesized that both the systems change and the healthy change would have a greater impact than the education or control effort alone on BMI. It is an intent to treat analysis, which means regardless of what happened to the kids, if they dropped out, if they were not seen, they stay in the study. So if they came to 5 interventions and intervention sessions and never came back, they are still considered in that intervention. Does that make sense? Okay. So our outcome is a trajectory or a slope of BMI over time. So it is baseline 1, 2, and 3 years. It is a linear slope, adjusting for BMI at baseline. And also we controlled for the clustering at the school level at the beginning because of the way we recruited. So I'll let you just look at this very quickly. And as you can see, the BMI went up in every group. But the question would be then, is there a statistical difference in those changes? And I will tell you that there is no statistical difference to those 3 lines. In spite of the fact that the green line, which is healthy change, looks as though when you look to see the difference in range, it's not clinically important. All right? Okay, let's take that in, because it was very disappointing to all of us to hear this, and actually shocking. I will tell you that we, as our director, I went back over again and said, are you sure that our groups are categorized right? Right? Because when I first saw this, I would have thought maybe these were our 2 intervention groups and the blue was the control, just by looking at it, right? But the bottom line is that the slopes are not significant. By the intervention, meaning that the intervention did not have a role in reducing. But more importantly, I think what you see is what? It is one significant, for kids, so these are 11-year-olds when we started, their rate of increase in BMI is significant, period. This could have looked like lines, right? It could have been 3 lines straight across, meaning that there was no change in BMI and there was no difference in intervention. This shows everybody gains weight and the intervention didn't stop it, basically. Okay? This is just the analytic part. I'm not going to go through the statistics part of it, other than just, again, say non-significant. But then this was probably the more depressing part. So then we ran our intervention effects against all of these secondary outcomes. On diet, on physical activity, on sleep, on stress, everything on our cardiovascular outcomes. There were no, now again they are slopes, so they are considered linear changes over time. There were no intervention effects on any of these outcomes. I'm going to come back to this in a minute because I feel like we should do this first. So we were pretty obviously like, oh my goodness, this is amazing. Put this much time, these interventions seem so solid. We got together with our copter studies, anxious to hear how they had done. So we wanted to know, did their interventions impact? Stanford, which is also treatment center, no significant impact. Vanderbilt, prevention, no significant impact. Minnesota, prevention, no significant impact. I'll pause again. Because take that in. 7 years of incredible intensity of folks that have been doing intervention research for a long, long time, and not to be able to slow this speed, this rate of change in BMI in kids that aren't just puberty, like our kids. You know, they were already sort of here. We're talking 2-year-olds. Could not slow the trajectory. And I tell the story of often the Vanderbilt, Sherry Barkin, who's the head of pediatrics at Vanderbilt, she presented the presentation initially of her slide, and it was 1 line. We're all like, okay. She says, I'm sure you're waiting for me to put the second intervention group up there. And then it spread apart, and it was the same line. There were 2 lines. It was just identical. So in her case, now, this is just for BMI, but what she said was, don't just look at that, look at the trajectory. These are 2-year-olds. We did our best, and there's no difference, and it is a trajectory straight up. So taking that in, I think, I will say, you know, we want to know what this means, and, you know, if this level of effort didn't work, what will it take? And I've said, as many of you may or not know, I just came off of a 6-month sabbatical where I really was able, thankfully and gratefully, to spend time with these 2 lovely ladies, spending a lot of time in this data, figuring out where we're going to go with this. And I've decided that I think that the new mantra for our PRC ought to be, what will it take? Because what will it take? What will it take? Can't be more of this, because more didn't work. And I will say, when we presented this to NIH right after the Obesity Society, somebody fairly high in the NIH stood up, who's the person, his branch funded this, said, these were not the results we wanted to hear, but they are the results we needed to hear. So I think that was very powerful. Now, where they go with it, and because, I'd like to spend some time talking quickly about what does that mean, because if this didn't work, and even with this group, as we went around the room, a lot of the investigators kept saying, well, we could tweak this intervention, we could tweak this. And you just I wanted to, and I sort of did, sort of say, can we get out of this individual's cognitive orientation to losing weight? This obesity issue is much bigger than this, and it obviously involves more than what you put in your mouth and how much you move. Yes, that is a big part of it, but if families don't have resources, if there's a lot of things that go into that. Okay, so let me go back real quick. So then we did look at the impact of the We Run This City. So the first one is just exposure, which is really the way you're supposed to study interventions, right? It's an intent to treat. So basically we took the kids that were in a school that had We Run the City, and they were in the school, and they joined the We Run the City and attended at least one training. So of those kids, there was no difference in BMI outcome based on that exposure. Okay? A little disappointing, because we have a paper that's coming out right now that in the long evaluation we did see a little bit of changes in BMI. But I will say we saw very similar, though. We have seen a decrease in systolic blood pressure among the We Run the City kids, and this finding is replicated in the original work we had done, so that was helpful. What's a little confusing is there was kids that participated had an increase in triglycerides. So again, you start thinking, okay, does that just balance this out? And there were no other differences. I should say the one other difference, which is one that has continued to perplex us, is that for how many years we did the evaluation We Run the City, the number one psychosocial change that happened was the kids reporting on their families' social support of them being physically active. How much did their families encourage them to be physically active? That changed from pre-post to post-test every year we did the study. And it happened here too. And it's not just did your parent drive you somewhere. Something happens in We Run the City, we know it, that engages, it gets families thinking a little bit more about their child's physical activity. Okay, so, that depressing part. But we did see some real change in kids. Okay? So you can see these are like really, I think almost all of them are just 2-year differences, right, you guys? You can see the change in some of the kids. So we know that we just have to figure out why it worked for some and not others. So now we're really working on secondary analysis. And I think what I want to do is really quickly just tell you some things, because then I'd like to give the time for us to have you guys give feedback. And we're going to write all this down, right? Because there's a lot of places we could go with this. So we already want to look a little bit about We Run the City, way more about We Run the City. Both Sarah and Rachel have been working so hard. We have data on the coaches and on the teams. So I think there's a lot of contribution that we can make about school-based fitness and about these kind of programs. And I think that'll come out of this. We also want to look at the impact of the moving and changing schools. We want to look at the neighborhood effects. As you'll see in a little bit here, Sarah's dissertation is looking at this component. The role of the food swamp. Does everyone know what a food swamp is? So when basically your neighborhood has only bad stuff rather than good. The role of the parent factors, dose, and then obviously the kids who may or may not have lost weight. So one of the places we started, is this the new one? Oh, there it is, okay. Oh, that's why. Okay. Started. So we wanted to first just get a sense of, okay, what's related to BMI of the kids when we started? Remember, they're 85th percentile. So we did this huge multi-regression. These are all these variables are in the model at the same time. And what we found was inordinance of variance explained. The things that explain BMI in the kids was, now sedentary behavior and physical activity are both measured by an accelerometer, okay, not by self-report. The more sedentary activity they were recorded as having, their BMI increased. But interestingly, also, the higher the level of vigorous and moderate activity also was related to higher BMI. I'll give you my feelings of why that happens. we asked the moms to go back when the kids were little, from the time they were birthed to 2 to 5, and said, was your child normal weight, overweight, and they assessed each point. So I chose the one that the kindergarten seems to be the area in the literature that seems to be a predictive, and sure enough here, if the mom perceived their child's weight as being a problem or being overweight when they were 5 to 7, it also predicted their BMI now at baseline. The mom's BMI themselves also was a predictor of higher BMI in kids. And interestingly, the more rules parents had about eating, the higher the BMI. Well, it's hard, you're right. What came first? What came first, yeah. But it also is probably that thing about, you know, you nag and you assume that by reminding your children to eat better, they'll eat better. Which they're not eating better. Yeah. But maybe more importantly, then none of these things, though, were related. So age or gender, you're going to hear about generational obesity. We asked the parents, how many of the paternal and maternal grandparents were overweight? So 1, 2, 3, 0, 1, 2, 3, 4. How many parents? Rules about TV. We also looked at some neighborhood level data. Sarah's work is not in this yet. We're in the food environment, and then also about their personal. Okay, so forget about the interventions for a moment. This is where they are now. So of the kids who started out as overweight, basically a third became normal weight, a third stayed the same, and a third actually increased their weight to be in the obese range. Okay? Of those that started out as obese, 20% of them went down a category. So I just wanted, this isn't statistical, it's just the idea of getting your head around, we have movement. Kids are losing weight, and they're gaining weight. So I think we have an opportunity to look at a lot of different things around this. So the next thing we did was we looked at the BMI trajectory over time to see what was predictive, using all of those same variables. The only thing we added was obviously over time was how many times they might have moved or how many times they changed school. And this is probably one of our most interesting findings. The number one, and I think it explains 20-some% of the variance of change in BMI is related to whether they changed schools. Not moved and changed schools. Changed schools. As you can see here, that's already controlling for the number of times they moved. So changing schools there's something there. We don't know yet, but I'm just, again, filter that around in your head.
Up and down, like it could have impacted it to go higher? Or
no, only higher.
Okay.
Yeah, so the more, I think it's actually the number of times. So the more times they change schools over the 3 years, the more likely that their rate of change in BMI went up. But interestingly, also what was related was generational obesity. So if they had, the more grandparents they had that were obese, the more likely that their rate of change of BMI over time also went up. So this, I'm glad that you're here, because I think that the concept of looking at the epigenetics and the things that potentially are happening, because you should know that in this model, mom's BMI is in here. I don't know where it is, but it's in there. Parent BMI. So this is controlling for the mom's BMI. The number of grandparents that were obese predicted the trajectory of BMI over time. Again, very, very quick analysis. Okay, very quick. Rachel has a project right now. We've been trying to figure out, like, okay, what can we learn from We Run the City? Very interesting factors. So this is looking at who basically stayed in the Rerun the City, who joined it and stayed in it. Rachel, is that right? So these are the factors that she has found so far that are associated with it. So the higher the BMI of the mom, the higher the likely that the child stayed in the program, which would obviously also make a difference in why the program has less effect, right? Because it's not a natural occurring thing. Now the parents are probably, if they're also trying to encourage their kid to stay in the whole time, right? This is the more that may stay in. The size of the team made a difference, right? So the bigger the team, the more likely they'd stay on it. Makes sense too, that maybe they don't get quite, what's that? More fun. Yeah, more fun. That's right. And teams with mixed events. So actually, the lowest retention was in the teams that only had 1.2. So that's interesting too, because you begin to think that must mean that the 10K kids are probably challenging them to stay in and participate. I'm sorry, I know there's not enough time to go through all this. So the kids could either join for race day, either the 1.2 or the 10K. So in We Run the City, kids are all the way up to the marathon now, right? So this program started out by being, you practiced in your school for 24 miles, and then you ran the last 1.2 in the marathon, hence made the marathon. And then as the program went on, the kids wanted more challenging, so the 10K was added, then the half marathon was added, and now some of the kids, these are high school kids though, are running the marathon. For We Run the City, for our group, it was only the 1.2 or the 10K that they participated in.
Many different events.
What's that?
Many different events.
Yeah, on the same team.
We're trying to see with the association,
Yes.
with the mixed event.
Yes.
Yeah.
So teams that offered their students both the 1.2 and the 10K, perhaps maybe more, those if they were on a team like that, they were more likely to stay in the program. Okay. As you can see, family social support. So the higher the support for physical activity, the more likely they were to stay on the program. They do a thing called the pacer, which is the number of laps they can complete in a period of time. The more laps they could run at baseline, the more likely they would stay on. Right? That makes sense too. It's already a basic fitness level. And we're not sure about this one, but we think that the kids that walk to school were also more likely. So these all kind of make sense, right? So these are just things to think about. This, real quick, I'll just show you this though, because we think this is something we want to really dig into. So as you can see, about a third of the kids made no changes. But then 20% of the kids changed residence but didn't change school. 16.5 changed schools but didn't change residence, and 30% changed both. So we have a pretty good sample of each group to be able to look at these things. But this is probably the most fascinating. So if you move from no changes to change in residence but no change in school but none in resident, this is the increase in BMI from baseline to 36 months. And I think what's fascinating is when you look at this, it's not even controlling yet. I mean, some kids stay in schools that are not supportive. So there's something, but there's a lot that goes into this. We don't know why kids are changing. We don't know what's moving. But I think that this is something for us to really dig into next. This is just the BMI, just to show you more graphically. But that's the one I think is interesting. So the gray one is the kids that didn't move but changed schools. This is just systolic blood pressure. Okay, so this is, hopefully it won't be too long. We all could be invited to hear Sarah's dissertation. This is her first aim of her dissertation. Sorry, I did not introduce you guys either. So Rachel Garnett and Sarah Jones, who has really been with me now these last couple months digging through this data, because as I tell a lot of people, I really thought this year was going to be spent writing the first 6 papers that have nothing to do with the stuff we're looking at right now. Because we thought it would be all these intervention effects, and we'd be studying this and this and this. Almost all of that is going into the one first paper. So for those of you that are in academics, this is real world. This is what happens. So now so we've spent a lot of time really digging into the data and figuring out what to do next. But I think this is fascinating. So what Sarah is interested in looking at is a multivariable, multi-level analysis that looks at home, school, and neighborhood food environments, and what impact that has on calorie intake and dietary quality. And what you can see from her baseline results is males consume more calories. That's not too surprising. But we asked the kids, not parents, right? Yeah. Basically, if these different unhealthy foods and foods are in the house, two different sets of lists. The more unhealthy food, the higher the calorie intake. The more healthy food, the lower calorie intake. So that's pretty. So it is sort of like but to see it is very important, especially when it's within a multivariate model. But this is probably the part that these two are probably the more interesting. Maybe is that there's a social support scale that asks people about what your friends and your family are they encouraging or are they discouraging around eating and around physical activity. Eating is do they offer you sweet stuff? Do they sort of offer inappropriate eat stuff in front of you? The more their friends were discouraging, the higher their calorie intake. All right, and then the last one is probably the most will be the most important probably that'll come out of this, based on that food retail data. So looking at a half a mile around the kid's address, okay, and around their school, the higher the proportion of unhealthy food outlets that are in that half a mile radius, the higher their calorie intake.
the definition of the unhealthy food? Is it a percentage of?
Yeah, so right now, this has been the discussion. I don't know if you guys have been hearing about us talk about this. It is like, it's
It's the number of corner
Stores.
stores, convenience stores, gas stations, and fast food divided by all retail and restaurants.
Got
So
Yeah.
all food available within a half mile.
Got it.
So if all the food that's available to you is considered unhealthy, then your intake will be higher than if that proportion is lower. All right? Okay. So I would say my take-home thoughts, and I'm sorry I didn't give as much time as I was hoping. This was a really well-done study. And I don't say just for myself, but I think on behalf of our team. I think, and we've been told all the way up to NIH, they are as shocked as we are because they say that everything was done the way it should have been done. All of the studies were done. They were strong study designs. The interventions were strong. They were evidence-based. They were theoretically driven. The intensive exposure and the interventions were intensive and long. There was rigorous and calibrated measurements and very high retention rates. Afterwards, families actually reported that they really did enjoy the interventions, and many felt that they had made changes. But obviously it was just not enough. And so looking through it now, we obviously know that family resources are low, families are highly mobile, their housing is very unstable, healthy food access is limited and can be damaging. They may not be in a space and time to take advantage of the strategies that are taught in the interventions, but I also would say that I'm not so sure that the interventions were appropriate to what they're facing. I think generational obesity and epigenetics is something that we need to look at. We did collect DNA. We have not done anything with it yet to figure out how we would use it to see if this is playing a role in the long term. While we had planned to study the environmental factors, they were not built into the interventions themselves. So the interventionists didn't talk to the kids about the corner stores, didn't talk about, because that was not a part of when the study was originally designed. I think today we would do this in a very different way. So clearly we need to look at the factors that we think predict the success regardless of the interventions and what served as barriers. We really need to understand the impact of poverty. And that's a big statement for not knowing really what to do next, but it is clearly what needs to be done. And we need to ask the families themselves what happened. And I think that will be our next step, is doing some qualitative study with the families and getting a better sense of what they think happened over the 3 years of the study. So not to say that our funders were the NHLBI as well as the CDC support for a lot of the environmental data collection through our Prevention Research Center. And this picture just makes me smile. So that's a part that getting ready to run over the bridge in River City. And this is Erica Hood, who just left us. sadly. All right, I am so sorry. I didn't leave enough time. But so I think for us, I think what would be really helpful is just to hear, what do you think? Like, where to go next? I mean, many of you are into this, you're into the same discussions. This really took a lot of wind out of a lot of us because we thought we did what we thought we could do. So what will it take?
So I'll turn the question back on you.
Yes.
Where do you stand with the study? Is this continuing with the funding or it's over?
The funding?
And also from technical point of view, you did mention you collected blood samples, so
Yes.
there's plenty of DNA if you still have any left.
Yes, we do. And we have blood set aside for DNA analysis period, yeah. Oh, there's much to come. The study itself this study funding is now ended. But I plan to put in something in June that we'll go back and do a qualitative study. But we could continue with the families, which is what we should do from a cohort perspective. But I would also say we need to mine the data that we have because we have so much data that we really need to answer some of the questions that we aim to have an impact on. Maybe.
First of all, congratulations to you and the whole team. It's incredible, and I feel your pain. One thing that was going through my
Yeah, you try to do it for a whole state.
Yeah, right. Is to wonder about the concordance with YRBS findings in terms of over the duration of the study, and looking both cross-sectionally and longitudinally at the different ages. do you see exactly the same slope?
I don't know, Jean, you guys looked at that not too long ago. Obesity over time in Cleveland schools?
It doesn't appear that there's been any sustained change in obesity or overweight.
But as kids get older, they're more likely to be overweight, correct? I feel like that's the original, right? So this is like more of a developmental change rather than a cohort change, which is what the YRBS would
So I
do.
want to know, is the change, that you all saw over time consistent with the level of difference in BMI that you see from younger kids to older kids? Or from
yes,
the
yeah,
fourth grade cohort
yes.
in 1 year to the sixth grade cohort 2 years later?
Yeah, that's a good. We have a lot, like this is the part, we've connected the data, but we haven't done much with it yet. Because I think the hard part is trying to figure out how do you take this normative data, because the kids move so much too. So trying to figure out like what school do you use, like which data do you use?
Yeah, and I don't think with the YRBS data that you could link individuals, their report from year one to the next, to the next, you know what I mean? So you lose that level of precision.
But just in the aggregate even.
Yeah, just the proportions and the prevalence of it, yeah. Good questions.
Have you taken those kids that were successful, like the 20% that whatever?
Yes. Yeah.
And compare them to the kids that weren't successful?
No, and that's, I think, it will be somewhat of the heart of the qualitative work. Once we figure out who's what, and then I think being able to go back and really get a better sense of what happened. I will tell you that Shirley and I had this great idea. We're like, okay, let's take all the kids that have all the resources that we think. Let's say if resources are a problem. So we took the families that hadn't moved, and there's a thing called FAD, which is family functioning. We took people that were at the higher range of family functioning. I can't even think of something. Did they have a car? Like we took all the things that we thought, took that group. And I will tell you, out of 360 kids, I think 50 families fell into this higher resource space. So it's a very small sample size, and then the kids were not obviously randomized inside there. But it was pretty equally proportioned, and there were no differences there. And actually, it looked just like the other results.
Yeah, but those would be interesting. So I'm interested in the, it sounds like you debriefed with the families. They said they enjoyed the experience and what kind of data you got there. And then just thinking about your ideas for sampling for a qualitative study going forward. It's really the outliers and the anomalies that you'd want to look at. So those that had high levels of resources and had no change is a very interesting group, as well as those who had very poor resources yet had change.
Yes.
So those would be two really interesting groups.
Or even the kids that moved schools and didn't. So one of the problems we don't have is, and I'll say because nobody's mentioned it yet, what's big in the research now are things like childhood trauma. And we have no measure of childhood trauma. We didn't do the ACEs. We don't. So that would be one thing. I just met with Larry Kleiman yesterday, and we talked about, if we go back in the qualitative, could we include the ACEs to see if we can't get some sense? Because I will tell you, the trajectory changes are more pronounced in girls. And so that's another, in my head, I'm thinking there's something else. And new work just came out, too, of showing that it is in African American girls in particular, the obesity rate is still it's as high and it's still growing. But yeah, just why the school change? That is a perplexing question. And we don't know why they changed schools. So we know Cleveland has school choice, so you can move your child many times, right? I mean, they can change at any time. Can I do something else I didn't do, and I really felt remiss about this. We need to say something else about why this project worked, okay? You've heard the wonderful partnership that I feel like the PRC's had with the YMCA for a long time, and particularly with Barb and her team with Cleaners in Motion. And I think Cleveland schools need to understand how unique, actually. People give Cleveland schools a rough time, but they are as genuine and authentic about what they do as you can imagine. So the only reason we have a 92% follow-up rate of these kids is because their nurses in the schools helped us find the kids. And if the parents, we asked the parents early on in the study thing, there's some things we did early on that were, although we did have to go back and ask, was say, if we can't get you to come in with your child, can we at least go get BMI at their school? So we had consent to follow them in the school, which was a great backup. But it's one thing to have permission to do that. And those of you that have done any work in the schools, It's a whole other thing of actually making it happen. And if it weren't for Deborah Lotion, who's head of nursing, and all her nurses, that would not have happened. So like basically Terry, yeah, no kidding. And Terry and Sarah particularly, like, to go take all this equipment and we're just going to do it in the school. And the schools allowed that to happen. So part of, we know that we would have been in the 70 probably % follow-up rate if it had been 70, 80% by the end, if we had been dependent on getting the families in on their own. So that's a lesson about partnerships. You want to do research in the community, you can't wait to the last minute. I mean, the schools and the YMCA, the idea of being partners from the very beginning, truly partners. Any other? Yeah. Hey, good to see you in a while.
Aside from ages, how sociodemographically comparable were the 4 research sites?
Very good question. Very good question. So all 3 of the other ones were more largely Latino. So Stanford was almost all Latino. Vanderbilt was almost all Latino. Stanford, which was our comparison in some ways, they were more mixed but also Latino. And theirs was interesting because they were like a suburb of Oakland. Oakland, no, Palo Alto, yeah. So which always made a joke because their income level was really high. And we were like, they're not low income. They're like, you don't know what it costs to live here. And so that in itself, and I will tell you, we should be honest about this. They didn't find BMI changes, but each of those sites did find some other behavioral changes. Like Vanderbilt did see a 100 kilocalorie difference in calorie consumption. And others, and I think even Tom's group in Stanford, they have all found smaller things. We have not, but I would also say our kids were also older, had already gone through puberty, almost all of them. And I do think our resources, we were one of the lowest from an income level in the 4 groups. So does that answer that?
Yeah, it is. But I did wonder too, like you said, the Palo Alto group, the Stanford group, was your comparable.
Yes.
Yeah, and I saw that the age difference was really quite stark, right? It was they were 7 to 11.
Yeah.
And you did 11 and
Well,
12.
They weren't to be comparable though.
Oh, they were
No,
not?
no, not at all.
Okay.
No, and that was always the interesting part of this. We all submitted these grants as if we were doing, I don't know, pay attention to the FOA, you guys. So it's clearly in there that we were going to be a part of a consortium, and we were going to do things together, and we were going to have this really strict research coordinating center, right? But I don't think none of us read it when we wrote it, right? And so we all wrote very independent interventions. So they weren't comparable in any way. But in some ways, at the end of the story, that's really important too. Right?
Really quick about the income, I just want to mention, because my family lives in the Silicon Valley and works in the Palo Alto area. You have to be very careful not to look at absolute income, to look at income adjusted to cost of living.
That's exactly what they did.
There's been big headlines how the chef of Facebook is starving and food insecure and can't feed herself and her family. So just because they live there and they have big numbers, it doesn't mean they can eat on them.
Yes, I agree.
That has to be very careful.
So I will say one more thing that is, this is me playing in the computer, so so in the data set. But what is interesting is I did break apart by race to look at the intervention effects. And what I do see is that the interventions in the Latino families seems to have, did you look at this yet? The diet and most of the dietary changes in the inside of the HEI, like the percent of fat and the percent of that, looks like there were bigger changes in intervention within that population. And that makes me want to think about, okay, what does that mean? Does it mean that Latino families in Cleveland, with information, have a better ability to act upon that? You guys, right? Is there better resources for finding foods that meet the things that were being said in the interventions? I don't know, but there's something, because that parallels to what the other sites found.
I would just say that might be something to look into in a cultural context, more than maybe a resource-based. Because if these families are from the same area, it's definitely more of the Latino culture is very family-based.
Yes.
For sure.
Yes.
And I was kind of going to say this similar thing. I saw breastfeeding study results and Latino families because of family support tend to be higher, and that's, babies born at Rainbow, so it's
Okay.
Pretty neighborhood kind of thing.
I wish we had a bigger sample, because it would be helpful to be able to, at least if nothing else, to kind of get a better sense of what did resonate. So.
Yeah, I have a couple more questions. Do you think that this same study would work in a suburb, say in Beechwood, Ohio?
Yes.
You really do think it would help?
Yes, because it's already
done?
It's been done. Well, not so much from the school piece, but from the two. Well, I'm not sure how much evidence there was before we went into with the RBNC one. Yeah,
that was scattered all over.
They were scattered all over too. I mean, in general, I would say to you, this has been my sort of my new aha that happened to me, which is that we're all getting big on dissemination and implementation. And we say we need to disseminate and implement evidence-based practices. But if those evidence-based practices were found to be evident in different populations, right? But I want to be careful, because I feel like I hear this in my head like from 20 years ago, where we went into tailoring of interventions. And what I'm afraid of is that we're going to move to saying, oh, we're going to go back to that individual tailoring of individually focused interventions, which is not the answer. That's my perception. To me, I think the next big thing is doing this large scale. And those of you that have been hearing my post-sabbatical thoughts, I feel like we need to do a Jeffrey Canada study in Cleveland on health, specifically on these kinds of things, on obesity, on diabetes, on diet and exercise, where you do an intensive, where you go in and do all these things at one time, but also you engage families from the very beginning to be a part of that. And it's not and making things easier. I mean, there's some folks that believe right now if people just had an extra $100 in their pocket, you could change this. Well, then that's a pretty interesting hypothesis, right? All this individual work of saying, well, you need to eat better, but if in fact you had another $100 in your pocket, you would eat better. Then we're missing the boat.
I think we've got time for one more question, and then I'll tell you.
So I just have a question. You said that you reluctantly drew blood samples, and I imagine it was on the other side of that, and then you repeated them. So have you looked at any kind of like metabolic memory type things and analyzed that? The labs, I don't know what they were that you drew. I imagine they were fasting lipids and stuff like that.
Yeah.
But so over the 3 years, I mean, BMI is your primary, but I think that would be an interesting secondary, because a lot of the longitudinal diabetes studies, they say that the early intervention might not show up in the beginning, but it lasts a long time. And even with your BMI, if sometimes these things take a minute to take effect. So these kids get older and they get into high school and they might remember some of the stuff that they did, and then they grow up a little bit and they might improve from the intervention. I would say some of our studies, we look at, I wonder what this kid would have been like if they weren't in the study now.
I mean, Tom, the group, the Copter group, two of those were in something called GEMS, which was a study where their original results showed no impact, but they followed the kids longer, and there was a after study change.
Exactly what
but I would say we did look at A1C, we looked at blood pressure, we looked at trying to think of all the other and as part of this, and there were no differences. But the data is there longitudinally.
It would be interesting to, if possible, to look at that again in another 3 years and see if it, I know that's, sorry, Carrie.
Well, just because you have to now engage and find them again, I think the chances of getting the 92% again would be very hard.
But even a small sample, just to see if there's any change.
Okay, so I think we need to end it there. Please join me in thanking Elaine for a great talk. Thank you all for coming. There's a sign-up sheet if you are new and aren't aware of it, but please do sign in so we know that who's attended and that we can also reach you for upcoming events. Next month, we're going to hear from Darcy Friedman and her team on the BCOP project. So we'll see many of you next month.